Okay, so today we are interviewing Dr. Erin Madden. We are talking about her paper entitled Intervention Stigma Toward Medications for Opioid Use Disorder, a Systemic Review. She's a professor at Wayne State in the Department of Family Medicine and Public Health Services. So my first question always is just to get to know you as a researcher a little bit. How did you get into this field, especially addiction research specifically, and looking at such a specific idea as in stigma?
So I came to addiction research as sort of like a more general health services researcher. I was at University of New Mexico and started working with Miriam Kamarami, who's a primary care physician who specializes in addiction medicine and is a former head of the American Society of Addiction Medicine. And she was looking for a qualitative researcher to help her with interviews for a study of people with co-occurring substance use disorders and mental health disorders. And so I hadn't focused on that population in general. I had just been looking at sort of more general access issues related to health care, especially among immigrant populations. But I thought, this will be interesting. And she sort of said, what do you know about substance use? And I was like, not a ton, other than like my own substance use, which like all of us do pretty much, who drink alcohol, drink caffeine, right? Whatever. I'm a former cigarette smoker, all of it. And so she said, what about, opioid use? Because that's a really common form of substance use disorder in New Mexico. And I said, well, I don't have a ton of experience, but, now that I think about it, I have a cousin who died of a prescription opioid overdose in 2006 accidentally. And then I said, and now that I'm thinking about it, actually, like one of my friends from college overdosed and died in New York City in 2013. And so I started to think about, actually this does, affect my life. And so I got really interested in it upon that reflection and also doing that project with her. And my training's in sociology. So stigma is one of our core concepts in sociology, right? Like Irving Goffman, pioneer of stigma research, was a sociologist. And so I started, through my work with Miriam Kamarami and sort of through my own sort of observations, realizing that the issues of stigma around substance use are so intense, which is not surprising, but that maybe there's features of that stigma that need to be better explored. And as a sociologist, I felt like maybe I could contribute there. So
when you decided to make your own lab and make your own projects, you decided to stick with the idea of stigma, or do you more look at opioid and this is just one way to look at it?
I mostly do research on stigma. So I'm very interested in the social processes around substance use, as opposed to a more clinical perspective about causes or, sequelae of addiction. I'm more interested in how people are treated and the sort of issues regarding not just attitudes, but stigma is also, discriminatory actions, how people are treated, right? Mm-hmm. So those are the topics that I tend to focus on. Of course, with my work with Dr. Kamarami, we're sort of looking at health services, but within that, we're interested in how clinicians, care teams, right, treat people who use drugs and how that care is perceived by those people and such. So
do you find that there's a lot of challenges that you have to overcome in doing research in such an amorphous idea? Like stigma can be defined many ways and it can be thought of many ways. And obviously it might be hard to get people on board with such a idea.
Yeah, I think in the past few years, there's been more attention to stigma, and the NIH and NIDA in particular have decided to put funding towards this particular issue, as well as other, funders like foundation grants and stuff. So I've been seeing more interest in the stigma issue recently. So I think I've come into this work, coming into this work around 2015, there was some stuff about stigma, but it's really picked up about since 2018 onward, an interest in stigma and a realization that stigma is not just about hurt feelings, that it has material effects on people's lives. It affects health outcomes. It's not, I hate it when people just talk about something just being hurt feelings, because we know hurt feelings actually matter for health outcomes. They're stressful, right? But also that stigma is not just about feelings or attitudes. It's about discriminatory actions and policies, people tend to have this sort of interpersonal idea of stigma. It's just me and you interacting, and I'm stigmatizing you, or you're stigmatizing me. But that's actually just one sort of subset of how stigma functions. Stigma is a much broader concept in sociology that includes like government policies that regulate methadone really highly, government policies that criminalize drugs. These are all types of stigma too. So I think that that conversation about sort of the breadth of stigma is happening a lot. I don't think I'm sort of a pioneer of that. I think that's a lot of people talking about that now in substance use research. So I think these ideas have gained significant traction, and this is not a hard area to be doing research in. A lot of people are interested, and a lot of like really exciting work is being done in this field. So
yeah, is there more researchers similar to your interest at Wayne State, or is it like just because it's a small university, there's not that many?
No, there's a few other people who are interested in sort of attitudes towards like medication treatment, like I am. And there's a few people who work in the social work department in the Center for Behavioral Health and Justice, who are specifically trying to address stigma and sort of attitudes more generally, not just stigmatizing attitudes, but sort of other attitudes as well, related to treatment and harm reduction in criminal justice settings. So primarily focusing on jails in Southeast Michigan and getting them sort of on board with naloxone distribution upon release and stuff. So there are other people who are doing this work in areas. I typically focus on healthcare, but I think what they're doing is really important and very exciting too.
Okay, it's good to be in a place that has multiple, so you can even collaborate or talk at the very least. Yeah, so frequently we talk to people who are conducting, specifically about papers. I'm sure you do have primary research, but looking at primary research. But I think that an important part of doing a review is that you get a good broad idea, and you can really see these broad strokes and where the general field is missing. Did you find that there was like surprising things that the field itself has been missing?
Yeah, so I created a concept called intervention stigma that just tried to do a little bit of work around how is the stigma towards like medications for opioid use disorders distinct from stigma towards substance use as a sort of condition, right? So I wrote a paper back in 2019 on that idea, and it doesn't mean I don't think those are related stigmas. They absolutely are. They reinforce each other. But there's also this argument that I think I've made effectively that, stigma towards medication treatment is also distinct in important ways because you see it occurring among people who work in treatment, who all want to work with the same patient. Everyone wants to work with people who use drugs. They're not necessarily stigmatizing that patient population. They want them to come into their services. Yeah. But there's a huge divide in treatment services between people who think medication treatment is legitimate and people who think it's illegitimate. And so that divide shows us that the stigma is not necessarily just about stigma towards people who use drugs, but stigma towards how you decided to treat, right, your condition of problematic drug use. Mm-hmm. So I decided, after writing that piece, that I wanted to look at, what else has been written about this type of stigma. No one had sort of made the theoretical argument. I'm a sociologist, so we have to talk about theory. No one had made that theoretical argument yet, but plenty of people had done research on this type of stigma existing and how it looked. So I wasn't a pioneer there really either. Right. So going through all of those studies, and I looked at about 30 that sort of met my inclusion criteria. People sort of found, this stigma operates among people who work in healthcare, both general sort of non-specialized healthcare providers, as well as people who work in treatment, and people who work in pharmacies, right? It happens across the sort of health services field. It also happens among, the general public, the friends and family of people who use drugs, but it also happens interpersonally within groups of people who use drugs, which I call peer stigma. So there's all these different ways in which it's happening. And that's, I would argue, pretty well documented. I think we kind of know what it looks like, and largely what's motivating it. So it's being motivated by sort of things like a deep, sort of value system that's tied to the 12 steps or abstinence-based ideas of recovery. It's also tied to lack of information sometimes, so misunderstanding of the way medications work. And sometimes it's also tied to sort of structural factors like policies that make accessing methadone really hard and feels stigmatizing because you're standing in line at, 6 a.m. What other type of healthcare do you have to do that for? You don't have to for other things.
Yeah.
So I think we have a good sense of what is causing it, what it looks like. So it also looks like not just having to stand in line in the US, but in countries where, methadone, for example, is dispensed in community pharmacies, it also looks like pharmacists, right, making you wait behind a bunch of other patients, even though you were there first, because they don't value you as much as the patient who's there for their asthma medicine, right? It also looks like people saying, I don't want to treat people who use drugs. I'm not going to be engaged in methadone or buprenorphine prescribing. I don't want to do that.
Mm-hmm.
So we kind of understand that. What we don't know, where there really is like very few, where there are very few studies, is how do we intervene or reduce or change stigma? We really don't have a good picture of that. That's part of what the National Institutes of Health and other funders are kind of looking for right now. There are some studies of stigma towards drug use in general that show that maybe some types of education and training could reduce stigma. Stigma towards medication treatment in particular, though, not just stigma towards the use of drugs, there's just not much there. What we think is probably training would help there. There's like one decent study that shows that with a cluster randomized trial, but one study isn't, build a consensus. We don't really know. And I would argue education, it only can change so much. There are structural drivers of stigma like policy, and we haven't tested getting rid of any of those, altering any of those that would maybe have a broader effect. We just really don't know. So that's the big area for future research, I think.
Yeah, because I noted that, and that was one of the things that I found pretty surprising, was that there was almost no research on like any sort of intervention. And I could see where you need the public to get on board before you can just like continually do education, because there's only so much you can do, and it will kind of force burnout if you continue like pushing this idea without any backing, So yeah, I definitely see where that's coming from. So another thing that I was going to ask was, you defined peer and self stigma, and then you had a dichotomy of like provider and public stigma were kind of like different things. These, you touched on it a little bit, obviously how they're different, but do you think that these types of stigma are rooted in the same place, or are they coming from like, one is coming from shame and one is coming from like public perception, or do you think they're kind of rooted in the same area?
I mean, I would think of them kind of like a Venn diagram where they have overlaps in which they reinforce each other, but sometimes there's sort of mechanisms that are driving one that don't drive the other. So like, for example, provider-based stigma, so stigma among individuals who are tasked with helping individuals who use drugs. Typically, we think of that as doctors, but it could be people like Child Protective Services, a range of individuals providing services. With those professional groups, I think it's not just about, I prefer the 12-step model because I've seen it on TV, which is one of the drivers of public stigma. It's also the lack of training that we baked into their training. So for example, right, in schools of social work, in community colleges that train a significant number of counselors doing treatment work, there is just no discussion of medications for opioid use disorders. They might be mentioned, but there's no discussion of really the evidence base for them. There's not much discussion about how do you support patients who choose these. What happens most of the time, for example, with people who are going to go on to be counselors after their associate's degree in a treatment facility, wherever they go to do their internship, whether that's a methadone clinic or a treatment facility that's based in the 12 steps, that will be a significant sort of a formative experience of how they think about medications. So the people who go work in a methadone clinic tend to leave their training with decently positive views of methadone, buprenorphine. People who don't get that exposure tend to have negative perceptions because it's not addressed in school, but they are learning people's perceptions in their internship. So I do think the training element is sort of specific to the provider-based stigma, and that is something I do think we could change. The challenge is, though, is that we have a range of providers
Yeah.
helping people who use drugs. And so it's not just like, oh, we can go to medical schools and solve the problem, because it's not just physicians who are doing this. It's a range of different service providers. So that'll be a big barrier for, addressing provider-based stigma, because it really is a diverse population doing it.
Yeah. And do you think like part of the reason that people haven't, because like even if people did studies and there were well tested ideas of what interventions you could do to stop stigma, like it seems like a concept that's too big to conquer. Like it's too big to do anything in, so you might as well not do anything, because you could put more harm than good. Do you think that that's part of it, or do you think it's just like there's just not enough studies, we don't have any idea how to fix it?
I wouldn't say don't do anything, but I would agree that it requires like a multi-pronged approach that would probably include things like educational training, of course, right, for people in training who are not providers yet, as well as people who are in the field providing services in communities already. We can't only focus on the new generation of providers, because we have people offering services who influence those people coming in too. So all of it needs to be trained. And then, there are people who've done, significant work that really hasn't been tested though, but it's still, I think, important, of doing sort of public information campaigns around naloxone. We see that in a lot of states with state departments of health, with billboards, places. And also, sort of smaller efforts of harm reduction groups trying to change the way their neighbors perceive them, like syringe distribution programs going out and doing things like needle pickups and showing that they're cleaning the community to the business owners around them. So there's also those sorts of ways in which people address public stigma that are not necessarily easy to assess how they change stigma, but I would argue probably do have an effect. The biggest goal, though, the biggest fish to fry for reducing stigma is the decriminalization and ideally legalization of drugs. It kind of feels like you're treading water in a situation where you're trying to address stigma and drugs are criminalized. Like it's like we can only do so much, because no matter what you're saying, what you're doing is illegal, and people have the right to arrest you for doing it, and it's not a public health problem, you are a criminal. Yeah. That framing makes it really hard to do destigmatization work in. So you can do all the public information campaigns, all the training that you want, you're only going to get so far, given the drug war in the United States. So that's the big challenge. Yeah, that is fair. Have you started the research, like literature search, in 1998? Did you find that like as the years went on that there was increased research in stigma and like better funded research, or do you think it's like been pretty steady and we're just kind of plateauing? I would say definitely it's been a lot more since about 2010. So very little before 2010, a few studies, like one in 2006, one in 2008 or so. And things really pick up after about 2010, 2011. So it's getting more attention now. And I would say, systematic reviews take a long time. There's been stuff published in 2019 and 2020 that I wish I could have included, but to redo all of full text reviews and abstract reviews and include those is just very time consuming, and then you're going to be late again. So you have to have a cutoff point, but there has been stuff published since 2019 and 2020 that offers some new insights, including some work on new interventions. Again, largely still that educational intervention approach, but because that's like, it's the most feasible, it's the easiest to get done. So I don't blame anyone for doing it. I've done that work since then. But I would just say it's a step. I wouldn't say it's not, I would say it's worthwhile, but it needs to be framed as one of many interventions that are needed, not as a silver bullet. Yeah. And I think like, it's also hard because like, if these are newer, even since 2010, we still like, there's still a step of like, this research has been done, getting the research out to the people, the clinicians, the like providers, whoever, and then doing that. So it's like this multi-step, like you were saying, it takes decades to get anywhere with this kind of stuff. So I could see that is going to be an issue for quite a while. So unfortunately. So my last question, which is a very broad question, if you could look at one thing and change one thing in this field, what would you change? I would legalize drugs.
thought you were going to say that. I just wasn't, you got to ask.
Yeah, and I know that seems like such a pipe dream at this point, because we've been in the war on drugs for so long. It's hard to, it seems like radical and too revolutionary, right, to think about that. But I actually see a lot of hope in some recent, legislative wins. Like the Drug Policy Alliance does wonderful work related to helping states and localities with legislative reforms towards, right, the ultimate goal of at least decriminalization, but ideally, right, legalization. And they've had wins. So, the state of Oregon decriminalizing drug use, having the state of Rhode Island allow people to test a safe drug consumption site. Like those are wins. Like just because it's hard and sort of full decriminalization or full legalization across the entire United States feels so far off, it doesn't mean you can't do more piecemeal approaches and get those wins, and then look at how that maybe changes measures of stigma. So, I mean, having those sort of structural changes should be assessed. I hope that people do sort of look at measures of stigma. We have several of these that are sort of like in a survey type of measure. One is like the social distance scale, which is used for all types of stigmatized conditions, but it sort of looks at how comfortable do you feel with having someone with this stigmatized condition sort of in your life. And that could be things like marrying that person, having them watch your kids, renting a room to them, right? Using that type of measure, but also doing qualitative research with just interviews. How did having this sort of legislative policy change affect your practice, your willingness to work with these patients? You could also do it in sort of more open-ended qualitative ways to see the effect of that. And stigma, I would argue, is often best measured qualitatively because it really is complex. It's about people's attitudes and actions, which can be really hard to measure in a closed-ended survey because you have to consider all of the possible attitudes and actions they might have. And sometimes there's ways in which there's unexpected attitudes and actions that are stigmatizing. So I really think, I feel very hopeful for the future. I hope, I think it's hard to do this work and feel defeated all the time. So I try to think about those wins a lot. But I do think, those are models that other states and localities can follow. That said, right, we also have losses, right? In places in Indiana and New Jersey have just tried to, through local actions, criminalize syringe distribution again. And so sometimes it feels like we also take steps back. But I think that largely people have become, in the general public and legislators too, have become very critical of the war on drugs and are trying to pivot more towards a public health approach. And I just think we have to keep that momentum. So
yeah. Well, thank you. I mean, you were a breadth of information about all of this. Well, thank you for talking to us.
No problem. Thanks for having me.
Yeah.